Well, first of all, I think we're delighted to be able to be part of this immunization economics series. The whole series looks really interesting, so it's an honor to be part of this. Where there are actually three of us, and who are gonna be talking about this topic. We're a group of modelers and health economists working on immunization at the London School of Hygiene and Tropical Medicine. So I'll speak first, and then I'll hand over to my colleague Kaja Abbas, and then last but not least, my colleague Han Fu will be speaking. So maybe what I'll do is to, maybe we can put it on full screen view if that's possible. Great, thank you. I'll give an introduction to the topic and explain why it might be interesting to health economists, and then give an overview of what we'll be talking about. So what I'm going to be talking about is, well, what the three of us will be talking about is really immunization, well, childhood immunization during the COVID-19 pandemic, and especially what are the economic issues. And I'm going to take quite a broad view of economics. If we can go to the first slide. I mean, when we talk about economic evaluation of vaccination programs, we usually think of it something like this, where if we're doing a health economic evaluation, whether it's cost effectiveness or cost benefit, basically we're comparing two worlds, right? So we see, well, let's say we want to compare a world where we introduce a vaccine versus a world where we don't. It might be, say, we want to see if it's cost effective to introduce, say, HPV vaccination in a country. Then we say, without vaccination, what are the costs involved in, treating the disease, the extra health burden? And then with vaccination, what are the costs? How much does the burden decrease? But also, what are the additional costs that we incur as a result of vaccination? So basically, we're trading off the costs and health benefits, or if you like, the costs and general benefits, depending on what framework you take, of these two worlds. Now, let's think about what's happening during COVID. Basically, we have the same framework. We're thinking about costs and benefits. And then if we can go on to the next slide, that'll be great. Yeah, we basically have the costs and benefits, and we're trading them off. And let's see what happens as if we're thinking not about introducing a vaccine, but we're thinking of it as a function of vaccine coverage. Basically, as you increase vaccine coverage, so the cost of vaccination increases, and the incremental cost of each dose tends to increase at higher levels of coverage, right? I mean, there's been a sort of number of papers that have shown that as you get to very high levels of coverage, the cost of vaccination increases, but it might still be worth doing that, both for equity reasons and also because the people who are hardest to reach are often the people with the highest burden of disease. Then there's the benefit function. And generally, the benefit function is a sort of inverted U-shaped curve. The reason for that is at very low levels of coverage, you're mostly just getting direct protection. You're not getting many indirect effects. As you get to higher levels of coverage, these multipliers of the indirect effects, the herd effects, increase. So for every person you're vaccinating, you're also protecting a lot of other people. And then when you get to really high levels of coverage, you get much low. Well, you've already reached the herd immunity threshold or close to the herd immunity threshold. In fact, the end of that curve might be below 100%. And so each additional dose has much less of an effect. So this is in a normal situation. Now let's think about what happens when we're looking at COVID. So we can go to the next slide, please. So during COVID, what happens? First of all, the cost curve goes up, basically, right? The cost of vaccination increases during COVID, the cost of any amount of vaccination, not only high levels of vaccine coverage. Why is that? The reason it increases is, first of all, there is it costs more to deliver a dose of vaccine during a COVID pandemic because you have to take additional precautions. I think Alison Portnoy and a number of other people have looked at this and showed this, people here at Harvard. Second of all, there's an additional cost of delivering vaccination during COVID, which is that, well, by delivering vaccines, you might be imposing a risk of COVID transmission. And so that's also on the negative, the disbenefit side of the equation. We have to take that into account. Third of all, the opportunity cost of your healthcare staff, using your healthcare staff increases because they're all busy dealing with COVID, or maybe delivering COVID-19 vaccines or treating patients with COVID. And so their time is more limited. And so because of that, the cost increases as well. However, the benefit also increases in the long run, maybe not immediately in the middle of 2020 when many countries were having physical distancing. There was not much transmission going on for many of these vaccine preventable diseases. But now as we enter 2021, 2022, these distancing measures are relaxed. And then we've got this whole buildup of susceptibles who haven't been vaccinated because vaccine coverage was low during COVID, haven't been infected as well. So we're building up these susceptibles for an outbreak. So actually, epidemiologically, the benefit of vaccination now is higher than before, because if you get high levels of coverage, you can avert this huge wave that has been stored up over the last year or so. So both the costs are increased and the benefits are increased. So the question is it still worthwhile to vaccinate, and should we even make more of an effort to vaccinate during a COVID pandemic? And so what we're going to talk about during our talk, maybe if we go on to the next slide, we're actually going to be looking at four different pieces of work that we've done, funded by various funding streams from Gavi, from the Bill and Melinda Gates Foundation, some of it through the Vaccine Impact Modeling Consortium. A first piece of work is, which I'll talk about in a moment, is looking at the cost function. What is the actual risk of COVID infection during delivery of vaccine campaigns? A second piece is looking at the benefit function. Actually, what is the impact of COVID disruptions to 3 vaccine preventable diseases? And what could we do if we start having campaigns to try to avert this? The third piece is something my colleague Kaja Abbas will be talking about, really looking at both sides of the equation, a benefit risk analysis of looking at the health benefits of vaccination routine vaccination during the pandemic versus the excess risk of coronavirus infection. And last but not least, my colleague Han Fu will be looking specifically at measles and saying, actually, what has the disruption due to measles vaccination, what has been the impact of it, and what might we be seeing in measles as a result? If we can go to the next slide, I'll start off by looking at the cost side of the equation. And this is really looking at the risk to vaccinees of SARS-CoV-2 infection, of delivering that during a vaccination campaign. So this is the risk to vaccinees and caregivers. There's another slide I can show showing the risk to vaccinators, which is a lot higher because they have a lot more contacts with vaccinees. Vaccinees only have 1 contact. As you can see, the risk to vaccinees is not so what we did was really look at 3 sort of scenarios roughly based on the demography of Burkina Faso, Ethiopia, and Brazil. So 3 countries which sort of represents sort of like 3 very, very young population, older population, and a sort of intermediate population as we go through these 3 scenarios, and looking at 3 levels of R0, which might represent, well, basically the reproduction number with some sort of mitigation in place. And what this shows is, if R is pretty high, we could get moderate levels of transmission, not huge, but still enough to be worrying. But this could be massively decreased with some kind of protective means if both the vaccinees and the vaccinators are wearing adequate PPE. So, you know, the vaccinators have a good standard of PPE and the vaccinees are at least wearing face coverings. If there's some sort of symptomatic screening of the vaccinators, so that, you know, at least I'm told if you're feeling unwell, don't come to work, and they comply with that, then actually the risk can be massively decreased by quite a lot. This was the main take-home message of this paper. It was just appeared recently in BMC Medicine. So this is on the cost side. On the benefit side, this is work done as part of the Vaccine Impact Modeling Consortium. Sorry, it's quite a busy slide, but it's basically looking at 3 vaccine preventable diseases and actually looking at the campaigns that were disrupted in 2020 and say what has been the impact of all this campaign disruption. And what this shows is that actually for meningococcal A vaccination, the effect of the campaign disruption hasn't been great, and that's because of these very large campaigns that were held in the past with meningococcal A, which is still protecting populations from getting meningococcal disease. However, for measles, the effect of campaign disruptions is probably quite big because missing out one or two cohorts can have a large effect on outbreaks. For yellow fever, it's sort of intermediate. It's not very obvious from the graphs, but there's actually is a risk of outbreaks if these campaigns are disrupted. It's just that the sort of like overall rate of transmission of yellow fever is not large, but these outbreaks could still be occurring as a result of campaign disruption. So on the benefit side of like the impact of these postponed campaigns differs quite a lot across diseases. Now I'll hand over to Kaja, who will be talking about routine vaccination and what's the benefit, costs and benefit risk equation. What does it look like for routine vaccination? So over to you, Kaja.
Thanks, Mark. So with respect to like the immunization disruptions, there are constraints from both the supply side as well as the demand side. On the supply side, for example, with respect to the logical constraints in the vaccine supply chain issues, reallocation of immunization providers to COVID-19 services, healthcare staff shortages because of SARS-CoV-2 infections among the staff, and also with respect to infection risk from the healthcare staff onto their households, onto their families, onto the wider community. So all of these things kind of really impede the supply side constraints. And in addition, on the demand side, from the community, from the families, from the parents, basically there's a decreased demand due to reluctance and fear of visiting vaccination clinics for fear of contracting SARS-CoV-2 infections. Next slide, please. And around March 2020, there were kind of deliberations that were going on what could be the potential impact of continuing this vaccination programs during the COVID-19 pandemic. And then around late March, WHO came up with the guidance basically saying, recommending like temporary suspension of mass vaccination campaigns. And during the course of the year, almost 65 vaccination campaigns were actually suspended. Around 60 vaccination campaigns were actually suspended during the rest of the year. And even for outbreak response vaccination campaigns, what was recommended is to conduct a benefit risk assessment, and only if the benefits outweigh the risk, then actually conduct those outbreak response mass vaccination campaigns. And this is for vaccine preventable outbreaks that could be taking place. And with respect to routine immunization services, they are actually recommended to be sustained, along with basically able to provide like adequate human resources, vaccine supplies, and also able to maintain like physical distancing and infection control measures. And all of these were actually issues that are actually affecting the continuation of routine immunization programs during the COVID-19 pandemic as well. Next slide, please. And the early modeling estimates that was basically based on the LIST model that looked at different scenarios. What if there are disruptions to maternal and child health interventions of like from anywhere between 10 to 50%? Or what if the wasting prevalence increased from 10 to 50%? And with respect to looking at what if there are constraints with respect to the availability of healthcare workers, availability of supplies, which can actually reduce the provision of health services, and as well as with respect to if the demand for health workers or health services and also for access for health services, these will impede the utilization of health services, thereby overarching the coverage of the health services will go down for this essential health services. And looking at like different scenarios with respect to moderate to more severe scenarios, there are initial estimates basically came up with around like almost 10 to 40% increase in under 5 child deaths per month that can occur as long as these like heavy, like more restrictions are in place. And also with respect to maternal deaths, again, that could be anywhere from 9 to 40% increase in maternal deaths each month, as long as these severe disruptions to maternal child health interventions and as well as if prevalence of wasting is increased. And so these are the early modeling estimates that are quite alarming. And next slide, please. And under this particular constraint, basically we looked at like, for example, what if we continue the routine childhood immunization, or what if the other way looking at it, what if routine immunization services is also disrupted, in this case in the context of Africa for a period of 6 months, what would be the potential impact? Next slide, please. And here we primarily looked at the vaccines that are primarily given the first year of life, which is basically looking at the vaccines given the first, second, and third visits, which is 6 weeks, 10 weeks, 14 weeks of age, or 2, 4, and 6 months, depending upon the country, primarily for the pentavalent vaccine, which is diphtheria, tetanus, pertussis, hepatitis B, hemophilia type B, and also the pneumococcal vaccine and rotavirus vaccine. and the vaccines that are given at 9 months of age, which is for the first dose of measles, rubella, first dose of rubella, meningitis A, yellow fever, and for the vaccines given in the second year of life, which is the second dose of measles. We did not look into the BCG, nor the birth dose of hepatitis B, nor the polio doses as well. And with respect to the health benefits, they are coming from the vaccine, based on the Vaccine Impact Modeling Consortium, wherein we look at benefits of immunization from the time of vaccination until 5 years of age. For example, by providing immunization, how many cases could be averted up to 5 years of age, or how many deaths could be averted until 5 years of age. Next slide, please. And with respect to the risk of COVID transmission or risk of like SARS coronavirus infections during the vaccination visits, we look at like how much of transmission could take place potentially at the clinic, how much of transmission could take place during the travel to the clinic, so at the community level. And then looking at the overall transmissions that can take place because of continuing the routine immunization program. And then once we have those estimates, we look at like how many of those infections are primarily attributed to the immunization program, meaning many of those infections could have also taken place in the normal interactions in the community. So how many excess infections that can be primarily attributable to the continuation of the routine immunization program. So thereby we estimate the excess SARS-CoV infections due to continuing the routine childhood immunization program. Next slide, please. So thereby now we have both sides of the ratio on the benefit side as well as on the risk side. So with respect to the benefits is the vaccine preventable deaths averted by continuing the routine childhood immunization program. On the risk side is the excess COVID-19 deaths from SARS-CoV infections acquired by visiting these routine vaccination clinics. And the benefit risk ratio larger than 1 indicates in favor of sustaining the routine childhood immunization program during the COVID-19 pandemic. Next slide, please. So that way, when you look at like all of these vaccines given in this during 5 vaccine related visits, so with respect to DTP3, hepatitis B3, like Haemophilus influenza type B, pneumococcal, rotavirus, first dose of measles, rubella, meningitis A, yellow fever, as well as the second dose of measles, at the household level, like 14 to 267 deaths can be averted by continuing the routine childhood immunization program in comparison to for each one excess death that can be attributable to like SARS-CoV infections acquired in the immunization clinics. And again, with respect to the vaccinated children, the impact is much more larger, like almost like 85,000 deaths among children could be averted for every one excess COVID infection that or excess death that can take place among children. And the reason for this is primarily because children are the primary beneficiaries of the routine childhood immunization program, while they are also the least risk of like severe COVID like related hospitalizations and mortality rates as well. Next slide, please. And then we looked at a much more conservative scenario, wherein for the period of suspension, what if none of these infectious disease outbreaks, like vaccine preventable disease outbreaks, if none of them really took place because of the physical distancing measures, the transmission of many infectious diseases were also reduced. And what if only there's a small chance of the measles outbreak, like we looked at like a 1/8 of a chance within those 6 months. Even in that particular extreme scenario, again, the benefit risk ratios are quite favorable at the household level for most of the countries. And especially with respect to the vaccinated children, almost 3,000 deaths could be averted for every one excess death attributable to the routine childhood immunization or to continuing the routine childhood immunization program. Next slide, please. So thereby, with respect to the implications for policy is that routine childhood immunization should be continued as logistically as possible as part of delivering other essential services during the COVID-19 pandemic, not only in Africa, but also pretty much this is broadly applicable to not only low and middle income countries, pretty much almost every other country as well. That being said, the service delivery model will require adaptation, including physical distancing measures like personal protective equipment and good hygiene practices in order to sustain the program in a much more safe and secure manner during the pandemic period. Next slide, please. And the benefit risk assessment tool has been put together now by like UNFPA, UNICEF, and WHO, wherein the health benefits of the essential health services are based on the list model, the life-safe tool model, and the risk part of the equation comes from the benefit risk analysis that we showed in the immunization model. And it has been pilot tested in 8 countries so far this summer. And now the tool is now accessible for countries for scenario building and epidemiological risk assessment to test out what could be the impact of potential disruption to essential health services, and thereby able to make their own decisions on any particular suspension or continuing their essential health services during the pandemic. And last one, please. And the benefit risk analysis study has also been, the children's version is now available in both English and French as well. So please feel free to share with children in your community and school teachers in your community. Thank you. And then Han will now focus on the measles impact during the COVID-19. Thank you.
Thanks, Kaja. So following Mark and Kaja's presentation, I'm going to talk about the COVID disruptions to measles vaccination. So with a focus on the long-term impact using transmission model in 10 high-burden countries. So this analysis is part of the work that's included in the preprint and involved many colleagues. So as we all know, like measles is a very contagious disease and may cause severe morbidity and mortality in children. And in the previous modeling analysis, the measles vaccination is an effective public health intervention that has reduced lots of childhood mortality over the past decades. And as you can see in the figure, so measles contribute to more than 50% of the deaths averted by vaccination in the past year. So that's the red bars. And recent stagnant progress in measles vaccine coverage pose challenges for measles control and elimination. And the COVID-19 related disruption to health services add even more challenges. So in the previous survey by the WHO, many countries reporting disruptions to their routine immunization programs, and this include measles vaccinations. And since in the previous slide we show measles has a really important role in child health, the disruption of COVID-19 to the measles vaccination programs might also have a large implication on the childhood health. So this analysis aims to investigate the health impact of COVID-19 disruptions to measles vaccination and subsequent effects on the measles burdens. So the model we are using, so the approach we're using is a dynamic model called DYNAMIZE, so Dynamic Measles Immunization Calculation Engine. And this model was used for previous vaccine impact estimates for policymaking. And since it's a dynamic model structure, so it's able to capture measles transmission during the natural history, and also to capture the indirect protection of vaccination. And as you can see in the figure for the model structure, we include several different states of the transmissions. And we also include 5 age structures to have yearly age group and weekly age group for the young age groups. We also incorporate country-specific data for demographic, contact patterns, and case fertility. And to capture the different protection effects of measles vaccination by different doses, we distinguish this population in our model. So we will be focusing on the 10 countries that has had the most measles mortality in 2000. So that's India, Nigeria, Pakistan, Ethiopia, and the other 6 countries. So the time frame we are looking at would be 1980 to 1950. So the first decades are for the historical period to capture the expansion of the immunization programs. And the projected period from 2020 to 2050 is to show the effects of COVID-19 disruptions. The metrics we are looking at is our cases, deaths, and dailies. And as we say, as I mentioned in the previous slide, we include different protection of the vaccination by different doses. And we also include 2 ways of the immunization programs, like routine immunizations to 9 months old children for the MCV1 and 15 to 18 months children for MCV2. And also the supplementary immunization activities, which have different target groups, depends on countries and years. And the historical coverage data will be extracted from the country-specific data from the WHO and UNICEF estimates. So for the projected period between 2020 to 2050, we set up 2 scenarios to look at the COVID-19 related disruptions. So in a non-COVID scenario, we assume the routine immunization continue as usual and with 1% increase per year over 2020 to 2050. And for the supplementary immunization activities, we follow the records saying that the 6 countries are planned to have SIAS during the year, and we assume they are proceed as usual, as planned. And for the future projection period, we assume that the SIA are conducted every 3 years with the same coverage as the latest round recorded. And in the COVID scenario, we took the 2020 unique coverage, which shows the various disruptions we will mention later. And from 2021 to 2022, the coverage, we assume the coverage of routine immunization came back at the level of 2019. That hasn't come back, but the program expansion of 1% increase are delayed to 2023. And for the SIAs, 2 of the 6 countries, that's Nigeria and India, are assumed to cancel as we see in the data. But for the rest of the future rounds of SIA, there's no impacts of COVID-19 disruptions. So based on these assumptions, we can see these are the coverage estimates for the 2 scenarios. So the yellow lines and circles are the non-COVID scenario, and the purple lines and circles are the COVID scenario. So for the routine immunization, we can see a variety from 0% to 6% decline of the absolute coverage for MCV1 and MCV2. And there's also 2 like purple hollow, it's not very obvious, in India and Nigeria, showing the cancellation of SIA in 2020. And these are another 4 countries that have no disruptions on the SIA, but still the disruption to routine immunization at various range. So using the coverage data we shown, we estimate the measles incidence over 2020 to 2050. So basically the results follow the disruption level of routine coverage and SIA coverage. For example, in India, the disruption to both routine coverage, routine immunization and SIA will lead to an increase of cases over time. And for Nigeria, also the disruption to routine immunization is not large, but the cancellation of the SIA, which was supposed to be a very high coverage SIA, will lead to a surge of outbreak. And we also calculate the cumulative measles burden over 2020 to 2050, and showing that the COVID-19 related disruption would lead to an additional burden of 6 million cases over the 30 years and in 10 high burden countries, and 97,000 additional deaths. In addition, we also calculate the additional burden in the first 3 years, which is in the blue columns. So this suggests that the additional burden in the first 3 years only contribute to less 5% of the total burden over 2020 to 2050. 50, which suggests that's a lasting impact of the temporary disruption. So also in this study, we didn't direct estimate the excess risk of SARS-CoV-2 infection for sustaining the immunization program. But from the previous study and what Kaja has presented, the risk of SARS-CoV-2 infection is very limited compared to the long-term effect we found on the vaccine preventable measles burdens. And also from the previous study, from the PROTECT studies, we also show that the excess risk of SARS-CoV-2 infection can be further mitigated by providing proper personal protective equipment and testing for vaccinators and careful timing of vaccination campaigns. And also there's there's uncertainty on the long-term health impact following COVID-19 infections, but this is not likely to outweigh the health benefits we found from sustaining measles immunizations. Since we are observing a long-term impact of the COVID-19 disruptions to measles burden, some measures could be planned and might be able to reverse the harm from the disruptions, which are conducting additional catch-up campaigns and or strengthening the routine immunization care in the post-COVID era. However, these all require further exploration and evaluation. And what I'm talking about here now is all on the benefit function, as Mark mentioned in the beginning. So there's also the costing function and costing side that we need to consider for sustaining the immunization programs. So that's also since that's a nice review of previous study showing there's additional cost of routine services during COVID-19 from the PPE as well as the labor cost for crowd controller or screening staff, and also hazard pays for the health workers. And there's also additional costs for conducting vaccination campaigns, and the total operational cost can be varied from an increase of 50% to 150%, depending on the intensity of the control measure. So this should be all included in the decision-making process. And these are some of the reference that we mentioned in all of these presentations. And we are happy to take any questions if you have.
Sounds like we were either so clear and comprehensive, there's nothing to ask, or nobody understood anything we were talking about. Hopefully the first. Why India cancelled the SIA? Actually, I think we're probably not the best people to ask, unless there's anyone in the audience who might know. I know India has had a pretty massive COVID wave recently. Not sure if that had anything to do with it. Not, should we hand back to the organizers to Karishma and Mary?
One is with respect to for the SIAs, like in the sense, not only in India, most countries were actually, all of them canceled their supplementary immunization activities for both measles and polio vaccination as well. But with respect to polio, some of them did get started later in the year, but predominantly most of the SIAs were cancelled. And in the context of India is also, India had a pretty severe lockdown, almost like a 3-month total lockdown. So thereby organizing these campaigns makes it much more difficult, both for the healthcare personnel providing the services and as well as for the families and children to actually take them to this clinics. So it's a kind of an issue on both supply and demand front as well. But it's not only India, most countries were affected in providing the supplementary immunization activities. And Arindam has additional thoughts on this. Yeah.
Yeah, thanks, Kaya. So yeah, when Mark was saying, I was just saying, but I was on mute, sorry. Yeah, so yeah, I mean, this is absolutely right. I mean, because of the rampaging pandemic, most of the countries had to cancel or postpone, and India is no exception. But there are some exceptions, I would say. So in the province of Bihar, which is quite large and populous province, they did conduct JE campaign during this pandemic. And that's one of the first campaigns actually in the world which was conducted during COVID-19 time. So there are some lessons from that, because the coverage, of course, was suboptimal because most of the schools were closed. And, you know, for JE, it's up to 15 years. So school going kids were one of the main targets. I would say almost 70% of the targets actually are from school. So that has some lessons. And then, I mean, the way COVID vaccination pace is picking up, I mean, that's also, I mean, takes priority resources and attention. And that also is one of the contributing factors to recalibrate your campaign calendar, keeping in mind, I mean, the other evolving scenarios. I mean, how much BTPVs you are identifying in your environmental surveillance when there is no case, and how many measles rubella outbreaks you are actually identifying, because India is also transitioning from, you know, to a broader case-based measles rubella surveillance as we speak. Over.
Question from Itama about how the push against COVID vaccination has affected hesitancy to other vaccination campaigns. That's a really interesting question. I don't actually know the answer. I mean, I think, I mean, putting the COVID-19 vaccine hesitancy is a problem, and it is in many countries. But I mean, there's, and I think it's been quite high profile in some of the high income countries in the West, but on a global level, I don't think, maybe we shouldn't over sort of emphasize, because I think there has been not more, I think it's safe to say there's not been more hesitancy towards COVID-19 vaccination than there has been towards sort of many other sort of mass vaccination programs in the past 10 or 20 years. So it is a problem, but not larger than for other vaccines, I would say. But if anyone wants to comment on that, maybe come in. That is a really good question, whether there has been any effects on sort of like attitudes to other vaccines. Have we done any evaluation of other high-income countries, whether there were any disruptions to vaccination programs? I haven't seen any evaluations in high-income countries, although I know that looking at the coverage levels, like in the UK, for instance, there has been a small decrease in vaccine coverage in the UK as well. I think the biggest effect has been on HPV, because that's delivered through schools mainly, and because schools were closed for part of the year, that suffered from the biggest disruptions.
Yeah. And with respect to the annual coverage estimates, both the WHO UNICEF estimates, they have been released recently, and also there's an estimates from IHME as well that kind of gives month-by-month breakdown for disruptions for MCV1 and also for DTP3. But again, these estimates are still, I would say, kind of evolving. These are still, some of them are model-based estimates. So we really do not know the exact full disruptions, not only in high-income countries, but also in low-middle-income countries. Is still, we do not know the full impact. And Arindam has, again, additional thoughts on this.
No, on the vaccine hesitancy piece, Kaja, I mean, which Mark was mentioning. Yeah, I mean, that's very interesting question. I mean, we don't have any first-hand data on that. I mean, I believe Government of India is taking help of certain partners to actually understand that. But I just like to flag one interesting point. So in India, we have seen both the ends of the vaccine, acceptance spectrum for COVID. We have seen extreme cases of vaccine refusal in case of rural areas, where people flee away from the vaccinators, hide in the bushes, jump in the ponds. All those anecdotal stories have surfaced. While in the urban areas, there has been long queues of the beneficiaries waiting patiently in line, and sometimes as because vaccine ran out, enough stock was not there, there has been some kind of a chaos. And the demand was so high, particularly around that second wave period, that there were fake vaccination camps which have been reported and then checked, investigated, and people actually got arrested for organizing fake vaccination camp. I mean, in a couple of camps, they just injected amikacin instead of COVID vaccine. So we have seen both the ends of the spectrum. So this is very interesting learning. For the same, at the same time, for the same vaccine, two kinds of people reactions we have witnessed, but there is a very clear urban-rural divide. There might be some kind of a digital divide contributing to it as well. As you know, India, has brought in a CoWIN platform to register and track each of the beneficiaries. Now, depending on your digital literacy and access, the rural people, of course, were at a little bit of disadvantage to take full benefit from that platform. But anyway, I mean, that is being corrected and being picked up. Over.
Well, thanks Arindam. That's really helpful context. I think that might be all for the questions. Thanks also Shafi for the question which Hannah's answered. Maybe we'll hand back to the organizers now.
Thank you everyone for joining in. If you have any further questions for our speakers, you can reach out to them. I'll be sharing the recording of the webinar post this. Thanks again and have a lovely day.
Thank you, everyone.
Thank you.
Thank you.